precursor of calcitonin. In this slide, we need to understand TNF alpha, interleukin 1 and interleukin 6. After bacterial infection, it is a pro-inflammatory mediator which responds to this mediator. Procalcitonin is secreted in bloodstream. On opposite to that, viral infection, TNF gamma, secretion of TNF gamma inhibited the PCT secretion in bloodstream. So PCT has been indicated to try to differentiate between bacterial and viral infection.
And the point is, to start with patient with the viral. Now that patient develops secondary bacterial infection. So whether viral infection will nullify the response of procalcitonin, because most of the time what happens? In pneumonia, 90% infections are to start with viral infection.
Yes.
Influenza હોય, respiratory syncytial હોય, HIV હોય, ગમે તે.
Yes.
So obviously, then to start with that, procalcitonin will be negative. Now after few days, maybe 3 days, 4 days, 5 days, patient sets in secondary sepsis. So what is the response? Why now the patient is in ongoing viral infection and now secondary bacterial infection?
Yeah, PCT is rising significantly. So the cutoff value for PCT is 0.25 to 0.5, but is increased to 2, then it is considered
0.5 to
0.5 to 0.25 nanogram per ml. 0.25 nanogram per ml is cutoff value. If it is persistently negative, there is a viral infection, but it is rising more than 2 nanogram per ml. So cutoff value is considered as a secondary bacterial infection.
So rising value is the more important.
Yes, serial monitoring of PCT is always important. So this is the how normal procalcitonin, calcitonin and catechin. This is the molecular basis of procalcitonin. This is the gene in which express and there is a secretion of procalcitonin. This is the sign in which normal endocrine cell, thyroid, can secrete the procalcitonin in blood circulation, but very negligible amount. But when there is an inflammatory process, when the bacteria's lipopolysaccharide membrane, microbacterial toxin, inflammatory mediator like interleukin 6 and TNF alpha can cause significant rise of inflammatory.
Punit, you will not have procalcitonin in serum.
Normally we have not any.
Procalcitonin is not secreted.
Calcitonin is yes. So this is the same slide. Bacterial infection, cytokine release of procalcitonin. The beauty of this slide is there is a multiple biomarker in which procalcitonin has all 6 impact: diagnosis of bacterial, duration, initiation, even discontinuation of antibiotic therapy, severity, mortality, and clinical stability. CRP is also much more value in this, but CRP alone cannot helpful to initiate or duration or discontinue of antibiotic therapy.
One more thing you can add here. When to step down or stop antibiotic.
Yes,
Discontinue
discontinue or de-escalation of the antibiotic clinical stage.
Only problem with CRP takes little bit more time to release and more time to decrease.
So, yes.
By the time if you see the CRP is high, but that patient's clinical condition is better.
Yeah.
You cannot clinically correlate between the CRP and clinical condition.
Yes.
Because if late to rise, then late to resolve.
But any time we as a clinician, clinical condition is always important. Patient has sepsis and procalcitonin negative, but you have a strong suspicion. The patient has a gram-negative sepsis, then you have to start with a good antibiotic.
Chronological order is the procalcitonin, then second is CRP, and third is ESR.
Yes. ESR sometimes negative in many conditions, and sometimes it is positive. So there is
So let me ask you one question, Punit. After initiation of severe sepsis, within what hour PCT will be elevated in your serum?
4 to 6 hour initial insult of bacteremia, patient have a rising titer of PCT. 24 hours to 48 hours it take to peak.
In
And
2 to 4
ongoing
hours
insult-
2 to 4 hours it will start increasing.
Yes.
The half-life of PCT is
24 hours.
22 to 24 hours.
And if
And
insult
at what, after severe sepsis, at what time CRP will increase?
CRP is also 24, it will take
48 to 70
24 to 48 hours.
No, I should date nothing. Check समय भी करेगा. It is also equally very early CRP rises.
When a CRP takes little bit more time, it is almost 48 to 70 hours.
But
And then the decrease come up and it was, rise is very slow.
In some of the cases where there is intense inflammation, like say chikungunya, you can start immediately also within 4 to 6 hours. Yeah.
So there is a recent publication of the this paper guidelines for the use of procalcitonin for a rational use of antibiotics. In India, multiple center has studied multiple evidence, review the current status and clinical judgment. Accordingly, they have
Sorry to interrupt. રામાએ એવું લખ્યું છે કે CRP rises within 4 to 6 hours of inflammatory response, doubles every 8 hours,
8 hours.
depending on the severity.
But the thing is, when bloodstream infection,
Intense inflammation જે આપણે કહીએ
but
chikungunya
localized
like
infection, there is
arthritis.
always
Sir, it will always be proportionate to the level of inflammation,
Yes.
but it rises within 4 to 6 hours.
4 to
Point is,
6 hours.
the rise will not, unless and until it is bacterial insult, your PCT will rise early. If it is viral insult, CRP may be increased into 50s and 60s in pure viral infection.
Sure, right.
So even if no bacteremia,
Any kind of physiological derangement, CRP will be
CRP, any inflammatory process.
CRP is a marker of inflammation.
inflammation, yes.
More the inflammation, more it rises.
Yes. So in COVID we are following the CRP, not PCT or
So similarly, PCT also marker of inflammation. It is derived by the cytokines, but bacteria are the main culprit which increases cytokine to that level that it increases PCT. Otherwise, PCT will be elevated in many other conditions
Yes,
as
absolutely.
well. But as far as infections is concerned, the level of high PCT will be seen in bacteremia more than fungal, more than viral or anything else, right? But
single reading of PCT has no value.
exactly, કારણ કે સર્જિકલ કોઝ છે, ઓટોઇમ્યુન કોઝ છે, બરાબર, ટ્રોમા છે, આ બધામાં જ PCT will be
Background
increased.
clinical condition is always there. Patient has a major surgery, cardiogenic shock, burns, pancreatitis, there is
તારું
a
પોસ્ટ
surge of
CABG વાળું સેપ્સિસમાં જાય તો you cannot decide based on PCT.
Yes, but serial marker of PCT with perfusion defect, organ
But
failure.
it will be always there in stress. See, surgery is CABG is a major surgery.
Yes, I agree.
બરાબર, તો એના બીજા ત્રીજા દિવસે ફીવર આવે તો you cannot decide based on PCT કે antibiotic step up કરવું પડે. That you need to take clinical judgment.
Yes, absolutely. And multiple time increase in PCT, background of surgery. So you can think that now patient is evolving sepsis or what. So you have to think on your insight.
સર્જિકલ ટ્રોમા 3 થી 5 દિવસનો તો ચાલે.
But rising trend नहीं आता. There is a
Why?
difference. Yes.
No, rising rate આવે. Rising આવશે.
But obviously clinical background is always helpful. So this is the class of recommendation. So simple question: can we do baseline PCT every patient with sepsis or suspected sepsis? So evidence says that PCT will rise after 6 hours and peak after 24 hours. So recommendation is baseline serum PCT in setting of sepsis will recommended, because if you know baseline PCT, you have a very good clue to monitor the PCT and infection level. What is the role of PCT in diagnosis of sepsis? Alone there is no particular role, but yes, PCT can help to differentiate culture negative sepsis from non-sepsis condition. Sometimes we are not able to grow any bacteria, any medium. So if serial PCT is rising, so you can stem this patient as culture negative sepsis. Should PCT be done for discontinue of antibiotic? This is the very widely described, because To start antibiotic is very easy in serious critically ill patient in ICU, but there is no any solid guideline when to discontinue or when to de-escalation of antibiotic. So there clearly says that procalcitonin level can be used to support the discontinuation or de-escalation of antibiotic in patient with sepsis. So this is the very earlier trial. They have clearly do a trial for reduce the exposure of antibiotic in ICU care when PCT is downgrade or negative. What is the repetition? When should PCT will be repeated? So in serious patient, 24 to 48 hours we should repeat the procalcitonin. The guideline says that 48 to 72 hours. So what level PCT should be used for discontinuation of them? This is the cutoff value is 0.25 to 0.5 nanogram per ml, or very simple 80% of reduction from baseline when you can think of discontinuation of or de-escalation of antibiotic therapy. Can we diagnose with the
Here now, mind is that there are guidelines for some of the infection.
Yes.
See, when it comes to acute pyelonephritis,
infected?
you have to give minimum 2 weeks. Minimum 2 weeks. Okay, so my mind is in each and every condition whether to monitor with procalcitonin is a questionable thing.
Yes.
When it comes to localized infection, you cannot guide that will not be guided by the procalcitonin.
So in deep-seated
Further infective
endocarditis, you have to give prolonged antibiotic irrespective of the medical condition.
And this is more for those who are having severe sepsis, critical illness, એમાંથી બહાર આવે છે એના માટેની છે.
And your patient is recovering in ICU.
Yes,
It's the routine normal sepsis like community acquired pneumonia, ventilator associated pneumonia, urosepsis, but more sepsis in ICU. So you have a very good argument that we can de-escalate or even we can stop the antibiotic for ICU patient. So yes, some patient is admitted in my ICU and PCT is very high. So I can explain the patient is a severe sepsis, clear-cut florid sepsis, septic loop, hypotension, AKI, acidosis, everything. So we can always predict the prognosis and severity of the infection when elevated baseline PCT. And this is also very good valid point. If serial monitoring of PCT have no any improvement, so something is going wrong. If one patient have a urosepsis, patient says that diffuse abdominal pain, but patient's PCTs keep on rising and patient is old age diabetic, and third day, fourth day by patient's abdominal palpation we found that there's some gallbladder issues there. So we urgently rush to gallbladder and there is a impending perforation, GB stone with severe cholecystitis biliary sepsis. So in this patient, we have a clue that we are not missing other than the routine sepsis or not. So in which we remove the GB and patient PCT will clear off after 48 to 72 hours.
So there is a catch point. If your kidneys are impaired, your PCT will be elevated.
Yes.
Okay, so then always you should keep in mind.
Yes. In acute kidney injury, 2 or 4-fold of the rise of PCT than the normal renal function.
So not only the acute, those who are having baseline CKD, there also PCT will be elevated. There are data available.
Yes. But in acute insult, there is definitely rise. So you have to judge, like troponin, you cannot jump on it is
Yes,
a positive
because
troponin.
it is a peptide.
Get to maximum dose.
So more than 50, then we dilute, then it come around 150, 200 also. In diabetic old age sepsis, very common scenario. So it is directly correlated with the severity of infection in sepsis. When patient is systemic inflammatory response sepsis, severe sepsis, septic shock, the procalcitonin is rising in critically ill patient with multiple organ failure. According to SOFA score, when the SOFA score is increased, PCT is proportionately increased. In pneumonia, Prop 64, 65 score, confusion, respiratory rate high, systolic blood pressure is low, age is 65. This score is also increased when PCT proportionately increased.
About 65 માં યુરિયા બી હતું ને?
આમાં પણ એવું નથી.
યુ નથી.
So, what are the infection in which PCT is not elevated? This is the very catch point. So, localized infection like tonsillitis, sinusitis, cystitis, uncomplicated soft tissue infection, even empyema. So, initial PCT will be negative. In atypical pneumonia, Legionella, Mycoplasma, Chlamydia. This is the subset in which you always confuse with viral, with COVID, with H1N1, and then atypical bacterial infection. In all cases, PCT will be negative, CRP is around 30 to 60, but patient has typical respiratory issues with hypoxia, impending ARDS or something. So, this is the catch point. You have to look for Legionella, Mycoplasma, and Chlamydia. So, malaria, Scrub typhus, PCT will be raised. And this is the debatable problem. In fungal infection, you may or may not rise in candidial infection. I have a separate 5-6 papers I will discuss later on about the fungal infection, and because it is very tough in ICU to differentiate bacterial infection to identify is easy. But when patient is chronically stuck in ICU and ventilator, day 3, day 5, day 7, patient develops secondary bacterial or overgrowth altogether risk factor of developing a fungal sepsis.
But here there is no mention of viral infection. So it is very good that it practically doesn't rise in viral infection.
Yeah,
Pure viral.
Pure viral, if it is viral infection. So false positive multi-organ failure, severe trauma, surgical procedure, cardiogenic shock, renal failure, and direct source of calcitonin and procalcitonin from medullary thyroid cancer or paraneoplastic hormone production. False negative, early course of infection. When patient come to you and PCT is negative, so we said that there is no any infection. But if patient has a background of immunosuppression, diabetic, and well preserved, but still you have a doubt of bacterial sepsis, so repeat after 72 hours or 48 hours or so. So timing and utility of administrator. So not PCT alone cannot help you for your clinical decision to starting of antibiotic. If you say that patient has a bacterial infection, so you can start IV antibiotic or oral antibiotic without waiting for a PCT. But yes, community acquired pneumonia, moderate to severe, baseline PCT will be helpful. Yes, it is clinical judgment to start. Don't wait for PCT to start empirical antibiotic. Yes, higher PCT levels are strongly associated with a typical bacterial infection.
So what is the
Clinical monitoring and de-escalation.
What is the highest level of PCT in which you have considered this is viral only and haven't given antibiotic?
Point, but usually if exclusive viral infection, PCT will always come negative. So patient is in ARDS. In COVID ARDS, we have multiple times do a PCT. Even patient receive tocilizumab, what not immunosuppression. So PCT will, serial PCT will be negative. So if it is pure viral.
Yeah, I am talking about value. 1.5 to 5.
So 0.5 is cut off.
I'll
But
give
you
you
can wait.
I'll give an example. If a viral pneumonia ICU માં આવ્યું હતું, બરાબર, you strictly have that instinct કે ના viral હશે. but PCT આવ્યું 3 and you have still not given antibiotic. આવું ત્યારે બન્યું કે દેવ પર આવેલા
ત્યાં સુધી તો વેઇટ કરી શકાય. PCT 2 એટલે બેક્ટેરિયલ માં છે ને હાઇપોટેન્શન થવાનું સ્ટાર્ટ થઈ જાય. યુઝ્યુઅલી ડે 3 ડે 5 ઓર્ગન ફેલિયર ના સાઇન મળવા માંડે. વાયરલ માં you can have a good blood pressure.
So about 2 you always give. That
Yes.
is what you show.
And try to find out there is a any source of sepsis.
એટલે સર્વે કર્યો છે કે ICU માં વાયરલ ન્યુમોનિયા હોય ને કોઈને એન્ટીબાયોટિક ના આપવું in spite of procalcitonin being negative.
So we need to cover with atypical actually.
એને આ બધું છે ને બધું બુકીસ છે COVID-19 કે શું કહેવાય ગેરોપેનમ ને પેલો ટાર્ગોસિન અને એ બધું મોમેન્ટ પેશન્ટ એન્ટર ઇન ICU before the equipment is available.
કોવિડમાં બી યુઝ્યુઅલી
એટલે હોમ કેર બેઝ હોય બરાબર છે પણ એવા એક કોવિડ છે કે જેની અંદર તમારે ના કહેવાય
Hardly I will hear from intensivists that they have not given antibiotics.
Yes, sir. But
Because the level of confidence is not there. In fact, when you read that procalcitonin negative bacterial infection is not there.
where in normal, if patient is not developed and no any risk factor, we can avoid to give
It's almost rare કે ICU માં patient
swine flu હોય તો dengue flu જ આપીએ. We cannot give
exactly પણ
antibiotics.
છતાંય તારી પાસે એવું ICU માં patient ક્યારે આવે કે જેને કોઈ એન્ટીબાયોટિક બહારથી લીધી નથી, બીજું કઈ પોલીથેરાપી થઈ નથી. He is always at risk once it reaches you. એટલે તારી પાસે કોઈ option જ નથી એન્ટીબાયોટિક આપવા સિવાય.
Hospital acquired risk also. The patient is
સ્વાઇન ફ્લુના બી પાસે એવા બહુ જ રેર કેસીસ હશે કે જેની અંદર તમે એન્ટીબાયોટિક નહીં આપો બહુ જ રેર કેસીસ અને એટ ઇન્ટેન્સિવિસ્ટ લેવલ આઈ રિયલી ડાઉટ કે જેને એન્ટીબાયોટિક નહીં આપી
But yes, this discontinuation, escalation of PCT level, આપણે આ સર આશીષભાઈને આપણે ફટાફટ PCT is negative, then we reduce the all kind of antibiotic. At that time we also not sure what is the
What
reason
is
for
the
acute lung infection.
practice going on in spite of evidence? This is what.
There are multiple reasons in ICU, apart from just the PCT. For example,
Yes.
patient is catheterized, there is RT.
એકલું મોનિટર કરતા નથી
So
PCT
we
should not
sometimes are not very sure that he may catch up with something. That is the biggest flaw or biggest reason. And then somebody will jump antibiotic came now. And then he develops a sepsis of bacteria.
એટલે આપણે ICU માં આવેલા આપવી જ પડે.
Behind the mind, Prophet, intervention is always.
But you have a valid argument if someone is able to explain if we cannot give
If you are in
antibiotic.
isolation, no catheter, nothing, just a ventilator which is external, maybe you may not.
I am not talking about this thing also.
Because it also
You evaluate કે ડેન્ગ્યુના પેશન્ટમાં then the dengue NS1 is positive. How many patients is without antibiotic? I will say 95% must have.
Knee jerk reflex. And any swine flu we start with azithromycin.
ચાલો આપણે ડિસ્કશન
So cutoff value 0.25, 0.5, severe disease, renal failure double than the cutoff value. Another is same guideline for hospital and ventilator associated pneumonia. Repeated is same serial PCT 48 hour to 24 hour in ventilator associated pneumonia 24 to 48 hours. We can repeat the procalcitonin. So de-escalation in ventilator is same. We can de-escalate after initial 5 to 7 days of antibiotic therapy. So cutoff is also same. UTI, this is the when there is a simple UTI where you get PCT negative, but UTI with bacteremia, you find to rise the PCT. So neurosurgeon when he does the endoscopic surgery and there is a bacteremia, then PCT will rise. So you have to consider to give antibiotic if there is a in cirrhosis and spontaneous or secondary bacterial peritonitis, PCT has same. Acute pancreatitis, they have clearly says that serial monitoring PCT with existing clinical score, all this score for NCT and necrosis will also help. So in pancreatitis, don't jump alone for PCT. So there is a multiple paper. This is PCT guided therapy to differentiate infected necrosis versus acute pancreatitis. Edematous versus
acute
necrosis.
pancreatitis, the initial 7 days, there is no role of any antibiotic. There is no role. And after 7 days, you find necrosis, at least you try to
Percutaneously.
એ કરીને કલ્ચર કરવાનું જો આવે તો એન્ટીબાયોટિક મળે, અધરવાઇઝ પેન્ક્રિયાટાઇટિસમાં there is no effect.
So they have trial in procalcitonin based algorithm, guided initiation, continuation and discontinuation of antibiotics. So secondary bacterial peritonitis is the direct predictor of septic shock and mortality. If PCT is very high or serial monitoring of PCT is rising, it is independent risk factor for mortality. So this is the in which you can encourage the antibiotic exposure and then there is a discourage or discontinue the antibiotic. So this is slightly dilemma, procalcitonin level in Candida versus bacteremia. So they have says that if bacteremia is there, PCT will rise, but in Candidemia, PCT values are not rising and you have to do other biomarker like beta 2 glucan. So not alone, stand-alone tool for differentiate between Candidemia and bacteremia. High negative predictive value of PCT for Candida isolation. This is also very interesting because in ICU day 7 patient develops sepsis, so you always wondering this is the hospital acquired, this is the de novo patient has sepsis in person or patient has a secondary fungal or secondary bacterial infection. So in day 3 up to day 3 of admission, PCT serum level will not significant rise with or without Candidemia. But in day 7, PCT will rising, so you have to suspect the Candidemia. So day 7, this is the very difficult to differentiate between gram-negative sepsis or patient develop fungal sepsis in ICU.
કેટલું PCT વેલ્યુ હતી આ આર્ટિકલમાં? હાયર એટલે કેટલી?
હાયર એટલે એ લોકો more than 50, 100 સુધી કહે છે.
કેટલા પેશન્ટનો ડેટા? This is tricky, આ believable નથી દેખાતું.
Yeah, but you, the article says inside that day 7 and rising of PCT, you have to think of fungal infection, that's all. If there is patient develop fungal or not, you have to independently judge.
But see, when you will start thinking fungal, 8-10 day of
Yeah.
ICU, right? Nobody lines and all blah blah.
Diabetic
સાતમા દિવસે
antibiotic
PCT
exposure.
વધવું, ઓકે, અને તમારું ક્લિનિકલ સ્ટેટસ તમને એવું લાગતું હોય અને ડાયરેક્ટ તમે એન્ટી ફંગલ આપો તો પોતે આપે સાતમા દિવસે.
No, empirical antifungal not.
ના એટલે આ સાતમા દિવસે PCT વધ્યું, will you give?
Now I just try to and step up the antibiotic and try to find out
Exactly.
the resistant bug.
Yes.
Our issue is resistance bug.
Yes. So rather a Candidemia વાળું તો, અને see these are the data of Candidemia versus bacteremia.
Yes.
It's not bacterial sepsis.
Sepsis.
Okay, એટલે this we need to always keep in mind.
Yes.
Bacteremia is different than bacterial sepsis, right?
And this is also says that if patient develop gram-negative sepsis, PCT cutoff value is very high. So PCT is jump up, so it is clear-cut indication patient develop gram-negative sepsis. So this is also same. So PCT is very helpful when CRP interleukin 6 and LDP lipopolysaccharide binding protein. And this is also very good. Acute kidney injury has more substantial influence on elevating serum PCT level than CKD in same residual renal function. If patient has AKI, the PCT value will rise. And this is also very important statement. PCT level of critical ill patient at ICU admission is an independent predictor of development of AKI within the coming 7 days irrespective of infection. So initial admission PCT is very high. This is an independent risk factor to developing a AKI.